This video's purpose is to show the nurse's role in an emergency Blakemore insertion. This bin is located in the endoscopy prep area with a pre-assembled Blakemore. This is a close-up view of the gastric and esophageal balloon ports in the pre-assembled Blakemore tube. Just remember, we have an instruction binder in our kit. It has step-by-step instructions and pictures to help guide you through. This is just a photo of the pre-assembled Blakemore tube as it comes in our kit. It's important first to understand not only how we place a Blakemore tube in the setting of a varicose bleed, but why it's placed. So this is for many reasons. Number one, it's a temporizer for a patient waiting for an endoscopist to come and perform a varicose banding. Also, it can be a patient is waiting for a TIPS procedure, which is a transjugular intrahepatic portosystemic shunt after a failed endoscopic banding. Most importantly, these patients are critically ill and losing a massive amount of blood volume. It is important to remember your ABCs. Airway and breathing. These patients are unable to protect their airway, so they are intubated and mechanically ventilated. Circulation, these patients are losing blood at a very quick pace, so in order to keep up with their circulatory needs, they will need blood and fluids. Stabilization is often started in the ICU or ER department, and you will most likely see pharmacological agents used in this setting, including vasopressin, a PPI, octreotide, and antibiotics, because this can enhance the survival in variceal bleeding and decrease the risk of rebleeding. It is highly recommended that each area have a pre-assembled Blakemore kit. Just taking a closer look at this pre-assembled Blakemore tube, you can see at the end we do have our gastric balloon and esophageal balloon. Distal to that gastric balloon are the ventilated ports to suction stomach content. At the other end, there's 3 ports: a gastric balloon port, an esophageal balloon port, and a 20 French suction tubing port. At this end of the 20 French suction port, there's a piece of cloth tape with 2 safety pins. This will be used to affix Curlex to traction once inserted. Now that you've got your assembled Blakemore kit, we're going to do some pre-checks. So we're going to start by filling a K basin with sterile water. We're going to take a 50 cc syringe and fill with air to inflate the gastric and esophageal balloons with approximately 50 cc's, and we're going to actively check each balloon for leaks. The balloons are now full and the stopcocks are turned to keep the balloons inflated. We're just going to put those balloons into the K basin and looking for bubbles and escaping air. Once we see that they're remaining inflated, we're going to actively deflate them. Lastly, we're going to mark the Salem sump tubing. This is just going to ensure that the tube does not go beyond the esophageal balloon once inserted. The Salem sump will be inserted after the Blakemore is inserted and traction is applied. This is just a step to prep for that. Once this is done, your patient should now be intubated. They're in supine position, and your head of bed is elevated to 45 degrees. It's now time for the physician to insert the Blakemore tube. They may choose to numb the posterior oropharynx or nostril with a topical agent, and will apply lubricant to the end of the Blakemore tube. A Blakemore tube can be inserted through the mouth or nostril. Have a gastric forceps ready to stiffen the Blakemore tube for insertion if required. A general rule of thumb, the tube is normally in place once the 50 centimeter mark on the Blakemore is at the patient's gum line. Check for tube placement by insufflating the 20 French port with approximately 50 cc's of air. Listen for gastric sounds. Once this is confirmed, attach a 5-in-1 adapter to the 20 French suction port and connect it to low wall suction. Next, you need your Conway dye and 5 cc syringe. Instill 5 mils of Conway dye into the gastric balloon port. Clamp and confirm placement with a portable X-ray. The balloon must be below the diaphragm in the stomach. Now the gastric balloon will be inflated by the physician in increments of 50 mils of sterile water. Clamp in between each installation of 50 mils to prevent leakage of balloon. The balloon will usually take anywhere from 180 to 250 mils. Once gastric balloon is completely inflated, place clamp with rubber tip. Next, attach Kerlix gauze to 2 safety pins and 500 to 1,000 ml bag of IV fluid for traction. Mark Blakemore tube with a felt marker where the tube exits the patient's mouth. A couple of centimeters of migration is acceptable as the tube warms and traction settles. But if the tube moves more than that, it could mean that the tube is settled in a hiatus hernia and you may need a chest X-ray. Lastly, it's time to insert the Salem sump. Line up the hatch mark on the Salem sump and 50 centimeter hatch mark on the Blakemore tube. Attach the two together with a piece of tape. If bleeding continues, physician may want to inflate esophageal balloon with 50 to 70 cc's of air. In summary, we do have a pre-assembled Blakemore tube that is kept in our prep area of our endoscopy department. Please ensure that you take a bottle of sterile water as it is not included in the kit. If you need additional Blakemore tubes, they are in Theater 1, and these are not pre-assembled, but instructions are in our manual. Reach out to your CNE or assistant head nurse for any questions.